Hello there, and welcome to another CPD talk. So, today we're going to be doing a very basic overview on acute transfusion reactions. The aim is with this, and there will be a follow-up one on delayed transfusion reactions, that there will then be separate presentations on the different types of acute transfusion reactions. Some of these are already present on the YouTube channel, but it's just so that people have a basic overview to get started. My name is Jasmine, and I am a senior biomedical scientist in blood transfusion working with NKPS. So, what we're going to be covering today is what a transfusion reaction is, and I apologise because this is probably going to be a definition that I repeat in several different talks. It's just a nice starting point whenever we're talking about transfusion reaction. What an acute reaction is, what acute reactions there are, a brief overview of each of these, and this will reference to any talks that have already been created, and what we can do to help prevent them from occurring or manage them if they do occur. So what is a transfusion reaction? A transfusion reaction is any adverse effects that occur as a result of a patient being transfused with a blood component or components. This could range from someone having a slight raise in temperature to someone feeling extremely unwell, leading to multi-organ failure, hemolysis, and possibly even death in extreme circumstances. There are two main types of transfusion reactions, the acute and the delayed. An acute reaction is one which occurs within 24 hours preceding a transfusion. This can happen as soon as when you are actually giving the blood component. So literally minutes after the blood starts entering the patient's body, blood, plasma, etc. Acute reactions are the main reason for staff having to monitor patients before, during and post transfusions, and as a standard protocol, staff should be checking the patient's pulse, blood pressure, temperature and respiratory rate, but we will come back to that. So what acute reactions are there? Within the acute transfusion reactions, you have mild, moderate and severe types of reactions, and you can also have varying grades of that type of reaction, if that makes sense. So the mildest one that you're going to get is a Fibril reaction. You've then got allergic or anaphylactic reactions, acute hemolytic transfusion reactions, bacterial infections, and then tacho and trali. We're going to start with Fibril. As I said, this is the mildest form of transfusion reaction and normally just presents with fever or chills. They're thought to be caused by recipient antibodies reacting with the white cell antigens or fragments in the blood component. So that's the patient's plasma is reacting with white blood cells in the donor component. And these reactions actually tend to occur more frequently in platelet transfusions than in any other component transfusion. Then when we talk about allergic or anaphylactic, there are two main types of these reactions. So you have the, and I cannot say this word, urticarial allergic reactions, which are normally mild and only present with urticaria, which is a rash, pretty much. And then you have severe allergic reactions, or the anaphylactic reactions, which have signs of cardiovascular instability and are much more dangerous. And we're going to focus more on the severe form because there's more to talk about. With either of these, though, normally caused when IgE antibodies in the patient interact with an allergen, usually a plasma protein in the transfused blood component. Some examples of when this would occur is if you've got a patient who's deficient in IgA and end up with anti-IgA antibodies in their blood. Or an allergen is transfused to a sensitive patient. So what you could have is a donor, before they go and give blood, will have been given some penicillin or nuts, for example, and then a patient who is allergic to penicillin or nuts is then given that unit, and there are trace amounts of that in the blood component, and therefore you end up with a reaction. and rarely the transfusion of IgE antibodies from a donor to an allergen present in the recipient. So that's when the donor is allergic to something and the patient has that allergy in their system. So it would be the reverse of the previous one. An anaphylactic or allergic reaction normally presents within the first minute to 45 minutes of the start of transfusion, and patients can present with any one of hypertension, cough, bronchospasm, laryngospasm, angioedema, urticaria, nausea, abdominal cramps, vomiting, diarrhea, shock, and loss of consciousness. These can be fatal. So that's sort of the basic overview of allergic and anaphylactic. I'm hoping to do a separate talk on these to go into them in more detail. We're now going to move on to the classic acute hemolytic transfusion reactions. Anyone who works in transfusion has probably heard of them. In fact, people that don't work in transfusion will normally be aware of ABO incompatibility because it's the most publicized sort of transfusion reaction and can lead to death as well. And that's basically where the recipient's blood, so the patient's blood, has antibodies present which react with the donor blood that's transfused. We routinely talk about ABO, but there can be other antibodies involved. Normally, though, obviously they're picked up in testing. For further information on this, there is a whole talk on the complement cascade, and it discusses a bit about the symptoms that you would expect to see in an acute hemolytic transfusion reaction. And I may end up doing a follow-up talk on that with some extra information at a later date. Bacterial infection, or which can lead to sepsis. So this is basically caused when the blood component which is transfused is contaminated with bacteria. This is rare because the components that we transfuse obviously undergo vigorous testing to try and prevent this, and their storage conditions are specifically designed again to try and prevent the the growth of bacteria within the units. If patients do get transfused with a unit that's contaminated with bacteria, depending on how much bacteria is present and the strain of bacteria, it doesn't always lead to a reaction. However, if there is a reaction, then you can have any one of the symptoms or combination of the symptoms below. So rigors, high fever, severe chills, hypertension, tachycardia, nausea and vomiting, dyspnea, or circulatory collapse. As well as this, the patient may develop shock with renal failure and disseminated intravascular coagulation, or DIC. And then moving on to the final section of the acute transfusion reactions, you've got TACO and TRALI. So TACO is transfusion-associated cardiac overload, and TRALI is transfusion-related lung injury. They're often grouped together because you get very similar symptoms involved. And although, as I said previously, the hemolytic transfusion reactions are the one that most people are aware of, it's actually TACO and TRALI in recent years that have caused the most morbidity and death as transfusion reactions. So they are very important. So TACO is normally the result of a fluid overload. So that's where a patient, normally smaller patients, are just given more fluids than their body can handle. Whereas TRALI is normally due to antibodies present in plasma products. These are HLA antibodies or human leukocyte antibodies. And in the past 5-10 years, what we collect from different donors has changed in order to try and reduce the risks of TRALI, and there have been less cases of TRALI as a result of it. So TACO is the main issue, but they are very similar in their presentation, which you can sort of see here. I've included a table. I'm not going to go through it all because I have done, again, a whole nother talk on this, which is quite comprehensive, and that's where I've taken this table from. So if you want to know more about TRALI and TACO, I recommend that you go and check that out, and I'll link that in the description box below. So I'm not going to spend the time to go through the treatment options of each of these. However, what I am going to go through is just good practice when it comes to transfusion reactions and transfusions in general. First and most important thing, before you even are considering a transfusion in general, is ensuring you have the right patient. Patient ID checks are something that people try and reduce the amount of time it takes to do, cut corners on, and they seem less important than they are, right? You're literally just checking again and again what the patient's date of birth is, what their name is, etc. However, the hemolytic transfusion reactions normally happen because we've got the wrong patient's blood, or because someone has picked up the wrong unit for the wrong patient, and it's just because they haven't looked properly. And normally it's more than one person as well, and that's why we have so many people that check and so many checks, is because it just takes for you to have a bad day, to miss a number, or to get a letter wrong, and you could be looking at a completely different patient record. So it's really important that whenever you're dealing with a patient in the hospital, you check who they are at admission, when you take samples, when prescribing any components, before the transfusion and after the transfusion. Performing these checks helps to ensure that the patient actually gets the blood they need, that you don't give the patient the wrong blood group and cause a hemolytic transfusion reaction, that you don't unnecessarily transfuse the patient. If you've got someone's notes messed up or you've sent the wrong bloods down to the lab, you're going to get the wrong results, and you might then ask for a transfusion that's not even needed and expose your patient to all of these possible reactions for no reason. And finally, that if all of the previous checks fail and you notice after transfusion, you can identify this and urgently start monitoring or treating the patient as is appropriate. So all of these checks are really important. Next thing is sort of comes in between all of those is when you are informed that a patient is going to have a transfusion, or if you're the person prescribing, when you're looking at the notes, assess the risks for that particular patient. Quite often, for example, patients who end up having TACO as a transfusion reaction have history of cardiac issues, or another one would be patients who have anaphylactic reactions may have had a history of past reactions. If you are checking back and looking at what the patient's condition is, you're going to be able to more easily assess how at risk that patient is and how many checks you should do to make sure that they are stable and that everything is going the correct way. Next thing, I'm basically going to repeat myself. I put the and in the wrong place here, sorry. But monitor the patient before, during and after the transfusion. Patients should be monitored for blood pressure, temperature, pulse and respiratory rate. And this should be done around 15 minutes pre-transfusion, as this gives you the patient's baseline, so this is what's normal for the patient. Because although obviously we have reference ranges, each patient is different. As I said in the previous slide, they're going to have different clinical indications, and therefore if you're transfusing a patient with sepsis, their temperature is probably going to be higher than a patient who's in because they're bleeding a little bit. It's going to be different indications and a different baseline for each patient. During the transfusion, you should then also check this, obviously, because if there's been a marked change, that is going to be your first indication that there is something wrong and there's a transfusion reaction and you need to act. And finally, after transfusion, in case it occurs a little while after, we're talking about acute transfusion reactions here, so within 24 hours from that transfusion. However, there are delayed reactions that can happen within a month. So it's important to continue to monitor the patient if you can. If you're not doing this, then you can significantly reduce the positive patient outcomes, because you might not notice, especially if you've got a patient that is unconscious. They're not going to be able to tell you if something's wrong, so these checks are even more important. So when you're on the ward and you're monitoring your patient, or just in general, the other thing that you really need to be aware of is the paperwork that is around in your hospital for transfusion reactions. whatever paperwork there is, it is going to be there to help you. So I have an example here, and it is one that is very common. You normally have something there to give you an overview of what you would expect from different acute transfusion reactions, and then you will also have a sort of flowchart where you're having a look at what is a mild, a moderate, and a severe transfusion reaction, whether or not you should be continuing or stopping it. So it's important that you familiarize yourself with these documents. Next is possibly one of the most important ones, is if you notice a negative change, or you're concerned about the way the patient is looking, or you just don't feel like it's right, stop the transfusion. It's always better to halt a transfusion than not to if you're uncertain, because it could be the difference between someone being slightly unwell and someone dying. If you halt the transfusion and the patient isn't having a reaction, then it can be restarted. Or if a significant period of time has elapsed, a new unit can be requested. Most hospitals have a decent stock of blood on site. If you need more, we will be able to get you more. If you don't halt the transfusion and it is a reaction, then as I said, you're putting someone's life at risk. Now, the final thing I want to put in here is listen to the patient. One of the reported symptoms that occurs in several of the acute transfusion reactions is a sense of impending doom. Now, I didn't go into that in too much detail in this talk because it's meant to be a really quick overview, but regardless of that, the patient is going to be the first person who's going to understand and notice that something is going wrong, because they know what their body feels like. So if you have someone who's saying they're in pain or it doesn't feel right, then just stop and assess the situation before carrying on. Your patient at the end of the day is going to be the best indicator of what is going on in their body. And that's basically all we're going to cover today. So it has been a quick one, and I know there's a lot of detail that's lacking, but as I said, we're going to cover a lot of it in other presentations, and I will link the one on the complement cascade, which is related to acute transfusion reactions, and the one on Taco and Charlie in the description box below. But what we've gone through today is that there are 5 main types of acute transfusion reactions. Each of these are dangerous in their own way, and anyone involved in transfusions needs to be aware of them. And finally, it's important to try and prevent transfusion reactions where possible by identifying your patient. However, if you can't, or if that step has failed or has no impact on the type of transfusion reaction, make sure that you're monitoring their vitals. And if you're worried that it is a transfusion reaction, then stop the transfusion immediately. I'd like to thank you all for listening. There will be a follow-up talk on anaphylactic reactions, as well as bacterial reactions, and an overview of delayed transfusion reactions. I hope this has been interesting for you. Please don't forget to do a reflection on the talk, and I look forward to next time. Thank you.